What we've studied is the resistance mechanisms in acute myeloid leukemia to traditional chemotherapeutics, since resistance is really the central clinical problem in acute myeloid leukemia. And what we found is that the TCA cycle actually provides the leukemia cell with resources to combat and restore damage that's been done after exposure to chemotherapy. What CPI-613 does is a pharmacological inhibitor of two key enzymes in the TCA cycle, both pyruvate dehydrogenase complex, which is responsible for entry of glucose-derived carbons into the TCA cycle, and also alpha-ketoglutarate dehydrogenase complex, which is responsible for glutamine-derived carbons entry into the TCA cycle. CPI-613 simultaneously inhibits both of those, so it prevents leukemia cells that are primarily driven by glucose and leukemia cells that are primarily driven by glutamine uptake, and it prevents the leukemia cell from switching from one source to the other since both are blocked. What we found was that when we block the TCA cycle, either pharmacologically with CPI-613 or in preclinical systems genetically by deleting those genes, we found an enhancement to the response to chemotherapy. And then we went on and did a phase 1 clinical trial for relapsed or refractory acute myeloid leukemia patients, combining CPI-613 with our traditional high-dose ara-c mitoxantrone salvage regimen that we use at Wake Forest. What we found was a 50% response rate in the 62 evaluable patients, which compared very favorably with our historical experience with the chemotherapy backbone without CPI-613. In particular, when we drilled down on the data, we saw that the benefit was particularly robust in those patients 60 years of age or older, which historically had about a 33% response rate. However, when we added CPI, that response rate was 47%. So a fairly marked improvement there. And the other group that seemed to derive the most benefit from the addition of this inhibitor were those patients who have poor risk karyotype. They tend to be very poorly responsive to chemotherapy, and historically we saw about a 19% response rate. In the current trial with CPI-613, that went to 46%. We've also done some preliminary comparisons of overall survival in those particular subgroups, our historical cohort experience to the current trial, and there was a suggestion of a benefit in the newer trial. Hypothesis generating, not proof. We're hoping to extend those findings in a randomized setting in the near future. We also went on and looked at baseline bone marrow samples for patients that were enrolled in this study, and we had 17 samples that had sufficient RNA quality that we could do an RNA-seq analysis. And we had 10 responders and 7 non-responders, and when we looked for the most differentially expressed genes between the groups, of the 20 most differentially expressed genes, 10 of them were associated with immune cell function. And so a suggestion that we may, through this signature, be able to identify patients who are more likely to derive benefit. Of course, that again will also need further validation in a randomized setting. So I think one thing that I would mention is that this approach is really very different from anything else that's out there. There are some other metabolically targeted agents that are in development in oncology, but none that are specific to the TCA cycle, and none that would have a dual inhibition like ours does. And so what we're finding is that those groups of patients would typically do very poorly when challenged with traditional chemotherapy. For example, those patients who have lost p53 function actually don't seem to, they seem to get the most benefit from this approach. And that's a really exciting part to me, is having a completely different way to attack the tumor is going to hopefully allow us to bring better responses to patients who've traditionally had really the most unmet needs.